I am in Michigan,
You're in
Detroit.
perfect. I'm in Saginaw.
Oh, lovely.
Yeah, so we're not too far. This is the first time I've had somebody from Michigan, so
Well, cool. I'm not from here, but this is where I am now.
here you go. How long you're going to be in Michigan for?
Um, that depends on if I decide to get married or not. So we'll see. We'll see what happens.
Okay, so we'll just give it a minute, and let the audience come in, and then we'll get started.
Okay. How many people do you guys usually have in these?
It depends. Sometimes, like, we also allow people to watch afterwards, so
Okay.
we do 2,000. Hey guys, for those of you who are coming in, if you guys just want to drop in the chat where you guys are from and what grade you guys are in, it'll help us to see what the audience mostly is. And we'll get started in about a minute. All right, I'm gonna get started. Today we have our guest, Dr. Bellens. She is internal medicine. She has her residency in internal medicine. She got her BS in biology, and she has her biomedical science and osteopathic medicine degree from PCOM. And her Instagram is up on the screen. Be sure to follow her out. She puts out great content. Her stories are great. I watch them. So be sure to follow her, and I'll get Dr. Bellens to start.
Okay. Hello, everyone. Thank you so much for having me today. I want to talk to you all kind of about what my job is. I am a nocturnist based here in Detroit, Michigan. One second, let me find my screen here. Should I put up my presentation at the same time as me talking? Is that possible?
Yeah, that's possible. Yep. So just
Okay,
you can screen share, and you'll be presenting on one side. So that'll be good.
perfect. Okay, let's see here.
And while she's doing that, throughout the presentation, if you guys have any questions, be sure to drop them in the chat. I'll try my best to answer them as we go, and if not, I'll get to it at the end.
Let's see if it will let me.
We got people from California, Texas, New Jersey.
Oh, wonderful.
Cool.
Well, my computer is not allowing me to share my screen.
One second. Yeah, it's enabled on my end.
Can you see it over there?
No. So there's usually after you click the green button, share screen, there's another button on the side. It's like a blue button. You have to share that too.
Okay. I think it's my computer. It does not want to allow me to do that. Let's see. Share. I'm sorry, guys. I didn't realize my computer would be so.
It's okay. We'll give it.
Let's see here.
While she's doing that, I had a couple announcements that I want to share. I'll get that with you guys.
Okay.
So for those of you who just started watching, I'll explain. We have a couple of things that we do. So for those who are interested in getting verification for your hours, we do that through summaries. So after the call, you can write a short summary of what you took out, about 3 to 5 sentences, nothing major, just highlighting what you took out from the session, and send us to email. All that information about where to send it to is posted in the bio or Instagram at Official Club Med. So be sure to check that out. Some schools ask you to have hours, so it's a great way to get some shadowing hours. I know during COVID, like this might be like the only way. It just depends where you go. It's some doctors are allowing, some not. So this is a great way if you're looking to get some hours. Other thing, we also have volunteering. All information about that is posted on our volunteering page at officialclubmed.volunteering. There's great opportunities that you can do from your house. All that information is posted. Wow, I see your screen. Awesome.
Okay, that
Okay.
should work.
Yeah.
Okay.
While she's doing that, so be sure to check out that's posted in the bio of at Official Club Med Volunteering, and all the programs that we offer and how to sign up is all posted there. And if you guys have any questions about anything, be sure to send them out to at Official Club Med or at officialclubmed.volunteering. Okay, I'll get Dr. Rollins.
Sorry about that, guys. You know, I'm an auntie, so I don't know technology very well, apparently. But my name is Dr. Wellens. Again, I am based out of Detroit, Michigan. Again, like he was saying, I got my bachelor's in biology at the University of Texas at San Antonio, and I subsequently got my master's in biomedical science at PCOM, Georgia, where I stayed for medical school. And I just recently completed my internal medicine residency and am now working as a full-time nocturnist. And this is what I'm going to talk to you all about. It's kind of a day in the life of a nocturnist is where we're going to start. And then we're going to go into what I think is a really cool case presentation of a real patient that I did have. Okay, so a typical day in the life of a nocturnist, actually, what is that? This is someone, these are your night walkers, your night owls that actually enjoy working during the nighttime hours. That has been me, and I discovered that early on in my studies. So what a nocturnist is a hospitalist. This is someone who works solely at night in hospital-based medicine. You can you can be an internal medicine trained hospitalist, family medicine, there's pediatrics that can be hospitalists, but these people do not work in clinics, in office settings. These people thrive, like myself, within the hospital system and within the hospital dynamic. Some of the pros of working as a nocturnist specifically is that not everybody wants to work nights. So we often are in a higher demand, and we can oftentimes demand a higher pay for that role. Further, the independence that I find during my night shifts is like none other. Unlike during the daytime when you are answering to a lot of different people all over the hospital, whether that's social work, case managers, speaking to families, none of that is really the case on nights. So I specifically get to go to work to simply practice medicine. I get to do medicine every single night and not have to worry about the day-to-day that goes on. And again, I don't have to speak. I love speaking to families. I call families all the time when something's going on at night, but it's not something that's going to interrupt my workflow typically. And then the beautiful part about being a nocturnist is that I get fewer shifts during the month. Now, I do work 13-hour shifts. So I work 6 p.m. to 7 a.m., but I only work 11 shifts in a 28-day cycle. So that's pretty awesome. 11 shifts over the course of basically a month. That gives me 20 plus days off, depending on the month. That gives me 20 days off to do what I want to do, whether that's enjoy my family, travel, sightsee. I get to do anything that I want to. And when I'm at work, I am at work. I'm focused on just medicine and the thing that I love the most. So those are the pros of working nights as a nocturnist. Some of the cons, which depends on what kind of person you are. Someone that really struggles with adjusting their sleep schedules is probably not going to thrive very much working nights. Because again, you get used to working nights for a set period of time, and then all of a sudden you're back to, walking with the day walkers. People who are up and at them bright and early, and you may have to go to early morning appointments and things like that. And it's sometimes a little hard to adjust. For something that I find that has been really helpful is blackout blinds or blackout curtains. So when I am asleep during the day, I am completely asleep. It feels like my night. So that's one of the cons. Something else is just that shift in the personal life and missing different events that typically happen, dinners and birthday parties and that sort of thing that can happen during the night shift. During your night shift, you just won't be able to be there, unfortunately. And then for Some people working alone is not something that they're into. They actually like the hustle and bustle of days. So this could be a con, it could be a pro for some. Um, I don't work alone. I have one other nocturnist that works with me about 95% of the time. It's rare for us to be on the shift by ourselves, but we essentially run the floors between the two of us, and we kind of split things up, our responsibilities during the night. My typical workday, so I arrive at about 6 p.m. and I get the admit / transfer phone from the day team. They sign out their patients. Really, they just sign out the things that are pertinent. If someone, they're suspecting of having a stroke during the day, or there's a lab to follow up on, or an image to follow up on, they'll let me know. And then I sit by my admission phone and I wait for the calls to come in from hospitals all over the state, sometimes from outside of the state. They call my line and they say, "Hi, Dr. Wellens, I have a patient that I need to transfer from my hospital to yours." And so that's kind of what I typically wait on. My hospitalist group in particular, we cover a wide range of things on nights. On days, they stick to their team and just their patients, but on nights, kind of one of the great things about nights for me is the challenge, because we cover bone marrow stem cell transplant patients, we cover lung transplant patients, we cover patients that are on the chemotherapy, that are getting their chemotherapies while they're inpatient. Advanced heart failure and LVAD. And LVAD is a left ventricular assist device. These are patients whose hearts have just completely tuckered out, and they are essentially on a machine that's kind of, attached to their body that is pumping their blood through their body. And then the telemetry floor is something that I also manage. These are patients that have like AFib with RVR, meaning really fast or irregular heart rates, electrolyte abnormalities. Maybe they're septic from some unknown source and they're just a little bit sicker. I also care for those. And the cool thing about working nights is that I also not watch over, but I kind of oversee the observation unit. Now, the obs unit is filled with patients that are not quite sick enough to be admitted onto my floors, but they're not, they're not well enough to go home from the ER. So these are patients with a mild pancreatitis. They might have come in with a mild chest pain, maybe an NSTEMI is what we call, with a little bit of elevated cardiac enzymes. So those patients are in the observation unit. And this is run by the APPs, who are the advanced practice practitioners. And these are the NPs, nurse practitioners, and physician's assistants. So they actively see the patients. And then I go down at around 11 o'clock and I round on those patients with them. They let me know if there's anything pertinent to find out. I go in, I see the patients, and then we have a team approach and we come up with a plan to try to get this patient out in the next 24 to 48 hours oftentimes. So my hospitalist nocturnist coverage is actually quite a wide range of illnesses and ailments, which for me, I find challenging, but it's one of those things that I like a good challenge, so. Okay, so kind of during the day, remember how I said that I kind of take the phone and I wait for those admissions to come in and the transfers? Between the two of us nocturnists, we get about 5 floor admits each. That's about 10 patients. Plus, we each get about 5 or 6 or 7 patients in the obs unit. So this can add up fairly quickly. We're talking 11 or 12 patients that we are managing acutely during the night for those 13 hours. But the good thing about it is that I don't have to round on every single patient on the floors. I simply manage the patients that I have admitted, and then I answer countless nursing calls. The wonderful thing about my job is that they granted me a lovely iPhone, and it wasn't just for me to have an iPhone, it's so that the nurses can actively reach me at any time. And they send messages through a secure system, and you can send images and things like that, and it's completely secure and encrypted. But I answer nursing calls all night long. And these are for things like, "Doc, the blood pressure is too high," or "the blood pressure is low," or, "Hey, Doc, I think I'm gonna call a rapid because this patient's heart rate is 160 beats per minute. It's been sustaining. Can you come check on them?" So that's something else that I am managing on top of these 12 or 13 patients that I'm getting during the night. I'm also answering all these nursing calls, which are coming from a wide range of those floors, from stem cell to lung transplant to heart failure to everything under the sun. Nocturnists, hospitalists, kind of, like I said, are getting hit at all angles, all different sorts of things. And then occasionally we'll have a rapid or a code blue, which I'll go to. The wonderful thing about my hospital is that there are residents. And so they typically run the rapids and codes. And as a baby attending, as much as I want to jump in there and handle those rapids and codes, I tend to take a step back and I let them run it and manage it themselves. And I just chime in if there's anything that I think that I need to add to the team. And then by this time, it's about 7 a.m. and the day team is trickling in, and I am handing them both phones and saying, I'm going home, I'm going to go to bed. It's been a great night. So that is typically the workflow of my nocturnist shift. Now, I would like to discuss with you all kind of a case presentation that this is a case that I actively participated in. And this is something that I get often. This patient in particular kind of took a turn and I wasn't quite ready for it. And we will go over how this case takes this turn. During this, I do want you all to participate. You're welcome to, type in the chat. I'm going to ask a few questions, ask for your input. Please, please, please participate. It would make me so very happy. So this patient's initials is IQ, okay? Those are the initials. And this is basic. We're going to go over this case as if you are the physician. We are starting from the top and we're going to work our way through this entire case together. You have a 55-year-old Indian American male who's coming in through the ER. His chief complaint is, Doc, I've been feeling short of breath. I'm weak all over. I've been fatigued. I can't really get out of bed. And I'm feeling like I have chills. Okay, this is a common complaint that many people are coming in with. And in the back of your mind, in the meantime, guys, I want you to kind of think about what sorts of disease process you think is going on. And one of the things that we always want to start with our patients is asking them, okay, what about your medical history? So this patient's medical history is type 2 diabetes, hypertension, he's got morbid obesity, he's had his left kidney has been removed because he had cancer, renal cell carcinoma, and he's got a social history of not much at all. He doesn't drink, at least he tells us he doesn't drink. He tells us he does not smoke anything, and he does not use any illicit drugs. So offhand, I'm gonna go ahead and give you our vital signs. If you pay attention here, we have a heart rate of 106 beats per minute. This is quite fast. It's not extremely fast, but it's fast enough to tell you, okay, something's going on with this patient. No one should be walking in off the street with a heart rate of 100. Blood pressure is a little bit elevated, 145/95. He's got a little bit of a temperature at 101.2 degrees, and he is saturating 93% on room air, which isn't terrible, but for somebody that has no lung pathology, he doesn't have a history of COPD or asthma, he doesn't smoke, that 93% should be kind of piquing your interest. He's got a fever, he's a little bit hypoxic, and he is tachycardic as well. So from here, you can begin, to sort of ask your patients some questions. One of the things that we always do with our patients is asking them a review of systems. This is a way of going systematically across the board for your patient, asking them head to toe questions that are gonna guide your differential diagnosis. So you can ask them, how have you been feeling? Overall, this is a generalized thing. Oh, I've been weak. Okay, great, we know that, we've established this. You can go with the head, ear, nose, eyes, and throat. So you can ask him questions about that. He says that he does not have a runny nose. He's got no blurry vision. Let's see here. And he denies nausea and vomiting. He denies diarrhea and constipation. He denies any urinary issues or penile issues like discharge and that sort of thing. And he says that he doesn't have any new rashes or lesions on his body. What he does admit is that this feeling has been going on for about 3 days. He's got these muscle aches and pains. He's a little bit short of breath. He does admit to some generalized chest pain, specifically on the right-hand side he feels, and he's got a decreased appetite. So all of this has been going on for the last 3 days. So in the chat, so I'm going to get to it in a second. In the chat, I want you guys to sort of give me what is on your differential diagnosis? Basically, what sort of disease processes do you think could be going on with this patient? And if anyone has any, please let me know. And there are no right or wrong answers, guys. When you start as an internal medicine physician, as a hospitalist, these patients are puzzles. And so you basically word vomit and you say, I think it's this, and this, no matter if it's a wild zebra or if it's something that's super common. And then we will go from there. We will get labs and images and we'll kind of pare it down. Anyone have anything? Not quite?
Pneumonia.
Okay, pneumonia is a great one to put on there. Great, I love that.
Lung infection.
Lung infection, good. Okay, that's a good place to start. Now let's go over a physical exam. Keep thinking, guys. So this patient, general physical exam, he looks ill appearing. He just looks like he's had a rough couple days. You know, like how when people look like they're just sick, he just looks a little sickly. But he is not in any acute distress. And then you can also, on a general exam, you can also comment on patients' size, like if they're obese or if they look frail and malnourished, you can comment on those things too. But anyway, this patient is obese, he's ill appearing, and he's in no acute distress. Cardiovascular exam, his heart rate is a little bit fast, but it's regular. It's not irregular, so it's a regular heart rate. There's no murmurs, there's no gallops, there's nothing that sounds out of the ordinary. On exam, you have decreased breath sounds throughout with a faint expiratory wheeze. Specifically, this was on more so on the right side of his lung, okay? His abdomen is soft and non-tender. You can hear all bowel sounds in all of his quadrants. On his extremities, he's got just a little bit of swelling on his lower extremities, but nothing extreme. And his skin looks clean, dry, and intact with no rashes or lesions. So those differential diagnoses, is there anything else? Let's go back and let's see what else is going on with him. He was a little bit hypoxic. So we said like a lung infection and pneumonia. Is there anything else that could be going on? His heart rate's a little high. He complained of some chest pain.
People said influenza, pulmonary edema.
Okay, good. What about in this day and age? If you have a patient that's febrile with shortness of breath and is hypoxic, generalized weakness, what big thing might pop up in your brain in this day?
Starts with C.
Huh?
COVID?
COVID. Okay, good. That's a good one to put on the differential. Let's go over some of these real quick. So remember, he's got, okay, so we said pneumonia. Good job, guys. Anybody with some chest pain, with risk factors for a heart attack, you want to think about a myocardial infarction. Someone that's got a history of hypertension, diabetes, and is obese, you want to think about a heart attack underlying all of this. You can think about a UTI and STDs as well. PE, meaning pulmonary edema, I like that, but also a pulmonary embolus. He could have a blood clot. Again, he's got risk factors, and that would explain the chest pain and the hypoxia as well. You can think about a return of his malignancy, causing that generalized weakness, myalgias, those sorts of things. Again, think about the flu and think about COVID-19, always at the top of your list, even for things that you don't even think about. Just put COVID on there anyway, this day and age. And then something else that might be a little bit advanced would be something like DKA, which is diabetic ketoacidosis. This is someone whose blood sugars are way out of hand. And if we go back, if we go back here, he's got some decreased appetite. He's a little tacky, those sorts of things, generalized weakness, that can all be explained by elevated sugars as well. Okay, so And there are probably a million more things, but this is a good place to start for most of these workups. Next, what do you think we need to order? What about blood work? Let's look. So labs, this is something that often when somebody is in the ER, they're gonna already have gotten blood because that's just what the ER does. They're gonna get blood for things like this. So you wanna check a basic metabolic panel. Everything was normal on this patient except for a mildly elevated sugar, so at 160, which is not that crazy. It's not gonna give us the symptoms of diabetic ketoacidosis, so we can rule that out on our list. His CBC, he's got a hemoglobin of 10.8, he's got a hematocrit of 34, platelets of 140,000, which all of that is fairly normal. And then his white blood cells are 14. 14 is elevated in your white blood cells. White blood cells are going to be indicative of some sort of underlying infection. Okay, so now we can kind of go back. Well, let's look again. Now, in order to rule out like a heart attack, you want to check a troponin, that is our cardiac enzyme. So we've checked the troponin. We're also going to check some liver enzymes as well as coagulation panel, and all of that was normal. Something else that we're going to take, because we are fairly convinced at this point that this patient has some sort of infection, is we're going to send off blood cultures and urine cultures. Wonderful. So we've kind of ruled out, let's go back. We've kind of ruled out the heart attack at this point. We would have gotten an EKG and it was normal. So we would have ruled that out. We have to wait on the UTI panel. Let's see what else we can rule out. Oh, he did get a flu swab. It was negative. He also got a COVID swab. It was negative. So we can rule those out. And then we can rule out our DKA. So we have ruled out quite a bit of this, that it's not this, it's not this, it's not this. We don't have enough information to rule out a malignancy quite yet. We probably need some sort of imaging to rule in or out a pneumonia or pulmonary edema or an embolus. Okay, so now let's get pictures.
Chest X-ray.
Perfect, I love it. A chest X-ray is absolutely gonna be right on the money. So one way of just a quick and dirty way of reading chest X-rays, you wanna make sure anytime you're reading images, and I don't care if you are a hospitalist, family medicine, anyone who's looking at images, you wanna have a systematic approach for these things. The way that I like to look at chest X-rays in particular is I like to go with the ABCDs, and the A stands for airway. So you wanna look at your trachea here. This lucency, this is your trachea. You wanna make sure that it's midline, which it is. It looks like it's not obstructed by anything. Good. So our airway in itself, you have the bifurcation here in the carina. So all that looks fairly clear. Good. So B, you want to look at your bones. Don't leave out your bones on your chest X-ray. A patient that comes in with chest pain and you get a chest X-ray, you'd be surprised what you could find within the bones. You could very easily have a fracture. Who knows? So you want to look at your bones, look at your clavicles, make sure that they're fairly even. This patient looks like he's a little side bent here. And you want to look at your ribs, make sure things look nice and smooth, which they do. This patient doesn't have much going on in their bones. A, B, and then C, I like to look at the heart, the cardiac. So you look at the cardiac silhouette here. The heart looks like it's a normal size. It's not taking up too much space. I don't see anything blaringly wrong with the heart. And then you have your great vessels of the heart, your aorta and such kind of coming off through here. But all that looks okay. So airway, bones, cardiac, and then D for diaphragm. So you're gonna go down to your diaphragm and you take a look here. You wanna look at the angles of the lungs. This is where the lung is ending and meeting up with the diaphragm. This should be nice and clear, which you should see basically it should come to a point. And if it doesn't come to a point, then you have a problem. Then you have something that we call like effusion or edema. Typically an infusion in particular would be down through here. So these are sharp angles. This looks great. One thing to note on your diaphragms, on your chest X-rays, your diaphragm on the right will likely be higher. Does anyone know why the diaphragm on the right is higher than the diaphragm on the left? What is sitting here? Anyone?
I'll give the audience about a few seconds to respond.
Okay. Okay, so actually what sits here is your liver. So the right side will be elevated just slightly compared to your left. Okay,
Yep.
so that's an always thing. If it's not elevated, then you have something else that's going on, and we're not going to go into that. So we've looked at the airway, we've looked at bones, we looked at cardiac, and we've looked at the diaphragm. Now you want to get to your lung tissues. Does anyone see anything going on? Go ahead and start typing while I go over how I read these. So I like to start from one side of the lung, and I like to zigzag. Hopefully you guys can see my arrow on here, but I like to zigzag, and I like to make sure that things are fairly symmetrical within the lung tissue itself. And for the most part, it is. But does anyone see anything going on, any sort of disease process? What's this in that right base, in that right lung?
Yeah, some kind of obstruction.
This is what we call a consolidation. It looks like this patient is developing a pneumonia. So whoever said pneumonia earlier was absolutely correct. This patient does have a pneumonia, which would explain that faint wheeze that I heard on the auscultation, as well as his right-sided chest pain. Pneumonia can cause the fever, it can cause sepsis, it can cause, the elevated heart rate. So that would explain that. And typically I would just, which I did, I started this patient on some antibiotics for a community-acquired pneumonia, and he was admitted to the floor. Now, usually in a couple days, patients should get better. I say should because patients do not read the books. They have no idea how to actually behave sometimes. And illnesses take a sharp left turn, which is exactly what this one did. And make sure you guys can actually see me. I think I have something on my camera. I wonder if that helped. So let's see what happens. On hospital admission day 3, this patient began complaining of a sudden acute onset of epigastric abdominal pain, as well as nausea. He was not able to keep anything down. Anything that he ate caused him epigastric pain. This patient should have gotten better, but when I went to go see him, he was looking so much worse. He had a dusky appearance. He looked even more ill than the first day that I admitted him. So anytime you have a new change in your patient, you want to make sure that you do a thorough exam, which I did. And on his exam, we had exquisite epigastric and periumbilical tenderness. Again, think about what could be going on. Where is this in the body? What disease process could be going on? You guys can go ahead and start typing. So he's got sudden onset of pain in his belly, and some guarding, meaning he does not want me to touch him whatsoever. And when I did lightly press on his tummy, he essentially jumped off of the table. Doc, stop. So I could tell he was not faking this. And then he had some mild tenderness in his left upper quadrant as well. So think about it, guys, start typing. So in the meantime, that same day, his blood cultures are now positive for Staph aureus. This is a bacteria that is very, very common on our skin. And during certain disease processes, it can get in the body and into the bloodstream. So his blood cultures are absolutely positive, 4 out of 4 tubes for this bacteria. He also has some elevated liver enzymes. And then the lipase that I checked that day was markedly elevated. Lipase is indicative of pancreatic issues. I don't know if anyone said pancreatitis within the chat there. They did? Wonderful. So
that inflammation of some sort. So
good, that works. So he's obviously got some inflammation, and his inflammation is of his pancreas. So now we probably need something a little bit more specific for the belly. What image should we get?
A CT scan?
A CT scan, yes. So what you see here is we're looking at a cross section directly through the belly, okay? So the patient is basically lying on the table coming towards you. So you're looking at the cross section within the body. If you look here, this is the spine. You have your kidneys here. And here, where the pancreas should be nice and calm and smooth, it is not. And what you see is that, like we said, with that elevated lipase, which is that pancreatic enzyme, as well as that very, very exquisite point tenderness of the pancreatic region, on our image, we see that the pancreas is swollen, it's inflamed, it is angry. But furthermore, we continue with the cross sections through the body on the CT scan. This large organ here would be the spleen, okay? The spleen should be nice and homogeneous, meaning that the whole spleen should be this color. What is this? This is something that you guys actually, I don't know if anyone's even heard of this before, but what is this black stuff through our spleen? This is what we call a splenic infarction, meaning that this tissue, this dark tissue, is essentially dying, but it is not getting blood flow. But why? Why is the tissue of the spleen not getting blood flow? Why is this patient's pancreas inflamed? Why does he have bacteria in his blood? Why is he not getting better after these 3 days of antibiotics? Now, this is even further than my knowledge at this point. At this point in the game, I'm confused as well. I'm like, wow, this is crazy. What's going on with this guy? So I get oh, and also at this time, this patient's heart enzymes start going up a little bit. So I actually consulted the cardiologist as well, and they recommended that we get an echo of his heart. Something is going on here. So an echocardiogram is an ultrasound of the heart. I'm not going to go over the anatomy of this at all. It is very complex. You kind of have to know where you are. These are kind of cross sections through the heart. What I want you to see, though, I'll show you the valves are what we need to pay attention to, okay? So I will attempt to play this. Oh, I hope that it plays. Oh, let's see. Yes, it's going to play. So what I want you to pay attention to is right here. This is a part of the valve within the heart, okay? This is a normal heart valve. It doesn't open and close, It's nice and smooth. That's the flow that should be going in through the heart, okay? Let's see if there's another angle here. Here's another good angle. Okay, these are your ventricles. This is the bottom of the heart. These are the top chambers of the heart, but you'll see the valves opening and shutting very smoothly like this, okay? The problem is our patient doesn't have this normal open and shut. Our patient, let's go back here. You see this little blurb right there. You see how it's not smooth? Let's replay that. This goes kind of fast. This is our culprit. This is a growth within the valve. Now this is the aortic valve here. This is a growth called a vegetation on the heart valve. And you see it kind of flailing around in there, causing all sorts of ruckus. And this is what started to stress our patient's heart out. Now, why is this a problem? This is what we call endocarditis. This patient didn't simply have a pneumonia. This patient actually had an infection of the heart valves that was going on. What I think happened is I think the pneumonia that he had, remember how we said that it was a Staph aureus bacteria in his blood? I think that the pneumonia was a staph pneumonia that seeded into the blood. And from here, that bacteria then seeded onto his heart valve, okay? Now, let's go over why the rest of his case got a little crazy. What happens with endocarditis? So typically what happens is, now classically I see endocarditis mostly in IV drug users. And if you think about why that would be, again, this is typically staph and strep bacteria that are getting into the bloodstream. Someone who's using IV drugs, constantly injecting with dirty needles and things like that, they're going to take that dirty skin flora and it's going to be pushed right into their system. So it happens like that, but it also can happen idiopathically or even um, spread through some other site in the body, like a pneumonia. So this patient had staph bacteria that went from the pneumonia into the bloodstream and then seated within the heart valve itself. And what happens is it leads to a cascade of clotting and coagulation, and the bacteria then begins to grow and develop into that vegetation. And if we look here, this is someone who's had their heart valve removed at this point, or an autopsy, and you can see this vegetation growing here. This should not be here. The tissue should look much smoother like this, okay? So you have your vegetations that are there. Now from here, that vegetation can oftentimes shoot off what we call septic emboli, teeny tiny microscopic pieces of itself that go within the bloodstream, and then it occludes or it stops off blood supply to other organs like the pancreas, like the spleen. So what happened is that vegetation shot off those emboli and it went through the body and went and attached itself right into the blood vessels of the pancreas and the spleen. And that is what happened with this patient. Some other issues that you can see, or some other signs and symptoms that you can see, even without doing an echo, these are some classic symptoms of endocarditis, septic emboli, wreaking havoc in other parts of the body. So these splinter hemorrhages underneath the nails, these are signs of septic emboli. You have these conjunctival hemorrhages as well, those little spots there. You can see what we call Janeway lesions, which are some spots on the hands and feet. And then you can get what we call Osler's nodes, which are painful nodes that end up on the tips of the fingers. And those are classic. These are going to be on your exams at some point. Trust me on that. This is a classic finding of endocarditis. Okay. So now my patient didn't have this. My patient only had what we discussed. But I thought that was really interesting, is that someone who came in with pneumonia subsequently ended up having endocarditis, and we ended up having to transfer this patient out of our hospital because his lesions were so large, his vegetations were so large that it was actually causing issues within his heart, and he had to go and have them surgically removed and treated. We weren't able to manage that at my hospital that day. And then kind of a what happens next is anyone with endocarditis is going to need long-term antibiotics. This is 2 to 8 weeks, oftentimes, sometimes longer, if they fail to clear that bacteria out of their blood. And then if you are at a facility that's not able to manage those really large vegetations like mine, then you may have to send them out for cardiothoracic surgery. And these patients are going to always, always, always have to be on antibiotics when they're going in for dental procedures or any sort of surgeries, because you don't want them to run into this issue again. Okay, so I thought that this was a really cool case. Does anyone have any questions about any of this? I know I talked for a very long time. Hopefully you guys found that interesting.
Yeah, that was a really cool case, how it started and took its turns to figure it out. So is he, do you know at the end, is the patient normal now with everything that he had to go through?
The last I've heard is that patient did undergo surgery and that he was doing well. That's all I know, though.
That's okay. That's good.
Yeah.
So this was a patient that came at like nighttime, or was he just there for a few days?
This patient actually came during the daytime. So this is when I was working days, but this patient came during the daytime, and I cared for him throughout his course during the days. But again, I see, and I just had 2 endocarditis patients last week when I was on night. So this is something that I see all the time, all the time.
Question, was this treatable by TAVR, TAVR?
Well, that would depend. That would depend on which valve this was on. I don't know if this patient ended up having a TAVR or what they actually ended up doing. But what this person is speaking of is a valve replacement or valve repairs that can happen. But yes, they would have gone in and surgically removed either the whole valve, replaced it with a cadaver, or sometimes mechanical. So there's all sorts of different valves that they use that I am not even privy to. But yes, he would have had some sort of valve repair or replacement. Absolutely.
Wow, that's really cool. Okay, was this patient put on long-term anticoagulation therapy?
Long-term anticoagulation?
Yeah.
I don't think this patient in particular was, but again, this patient was transferred outside of my facility at that time. But oftentimes it does depend, because if somebody gets a prosthetic valve and things like that, then they would need some sort of anticoagulation following that. Absolutely.
Okay. I think that's it for questions. Before we close out, thank you so much for putting this case. I think that was a really, really cool case. A few announcements before I go out. So I know we didn't have a call last week, but we'll continue to try to have calls every week. You can stay updated through our Instagram. We usually post information in the beginning of the week, telling you guys what it's going to be, and be sure to check us out. And we'll also follow Dr. Rollins on our Instagram. I'll put it in the chat. She puts cool stuff. And that's it from us. Thank you so much for everybody who came in. Thank you so much, Dr. Rollins.
Thank you so much.